A very good evening, everyone. We'll start the session around 7:40. Good evening, Sandip sir. We'll start the session in just 2 minutes. We are waiting for other panelists.
Good evening, ma'am. I'm available whenever you will allow me. I'll share my screen. Thank you so much for the invite.
Thank you, sir. Very good evening, everyone. Just will start the session in couple of minutes. We are sorry for the delay. Before we start the session, the housekeeping remarks for all the audience. They can just post their questions either in the question and Q&A box or in the chat box. All the questions will be answered at the end of the sessions. Thank you.
Ma'am, has everybody joined? Can we go ahead with the presentation?
So we are yet, two more panelists are yet to join, sir.
Okay.
Very good evening, everyone. On behalf of International Association for Integrated Oncology, IAIO, it gives me immense pleasure to welcome you all to today's IAIO Expert Insights in Hemato Oncology. I'm Joshi Roshni and I will be your compare for the day. We are delighted to have such a distinguished panel of experts and enthusiastic audience joining us virtually this evening. Before we begin, I would like to take a moment to sincerely thank our Program Director of the day, Dr. Jayachandran Sir, Consultant Medical and Hemato-Oncologist from Apollo Cancer Care from Chennai, for curating this amazing session. And I thank Roche team for supporting today's panel discussion. We truly appreciate their continued commitment to advancing scientific dialogue and education in hematology. So now I would like to invite our moderator of the day, Dr. Sandeep Kurkar sir, Director of Oncology from Park Geriatric Hospital, Mohali, Punjab. And The panel discussion is a case based panel discussion focusing on the management of untreated diffuse large B cell lymphoma, a topic of significant clinical relevance. And I would like to introduce our esteemed panelists, Dr. Induja MV Ma'am, consultant medical oncologist from Kaveri Hospital from Tirunelveli, and Dr. Jerin Ovitzer, a consultant medical oncologist from Holy Cross Hospital, Nagarkoil, Tamil Nadu, and Dr. Lingeshwaran S. Who is an assistant professor from Government CMC Coimbatore, and our last panelist of the day, Dr. Naveen Sir, who is a consultant medical oncologist from GVN Hospital, Tiruchi, Tamil Nadu. So, we look forward to an engaging evidence based discussion. I would like to hand over the session to our moderator, Dr. Sandeep Sir. Sir, over to you, please.
Thank you, ma'am, and thank you, Ross team, for giving me the opportunity tonight for an interactive discussion. I welcome all my esteemed panelists for their experience from their real world practice on polatuzumab and a bit about how what do they do in their real world scenarios when a patient comes to their OPD. So it's just an interactive discussion. We'll take some insights from whatever discussion we have and then apply it in our day-to-day practice. So I welcome you all, and with this I start my presentation. The presentation is purely mine and it is not based to influence you with any kind of uh, say inclination towards prescribing any drug. So that's a disclaimer. So I straight away go to my case, which is a 62-year-old male who presented with fever since 1 month, weight loss, a loss of appetite, hoarseness of voice, dysphagia, painless enlargement of the cervical lymph nodes. He had slight pallor on examination, hemodynamically stable. Clinical organomegaly was absent. There was palpable non-tender cervical lymphadenopathy. Enlargement of the tonsils was there. Hepatosplenomegaly was there, and he was diagnosed as IPI as 3. No anemia, platelets normal, LDH of 408, normal value was 240. FNAC was done, which was non-Hodgkin's lymphoma. Later on, tonsillar biopsy was done, which was suggestive of a high-grade DLBCL. Immunohistochemistry came out to be positive with CD20 positive, MUM1 positive, BCL2, BCL6 positive, and a high Ki67 of 80%. IHC was also negative for CBIC, cyclin D1, and CD10. So ultimately concluding as diffuse large B-cell lymphoma, non-germinal center type. So here I will take a pause and I'll have your inputs about how do we take the case forward, what are your thoughts about the case, and provided this patient comes to you in your OPD, what will be your thought process going forwards. So I'll start with Dr. Jarin.
So I would I think, complete a staging investigation, PET CT, and then moving forward, assess him whether he's fit for all our components, polar archer basically. And since there is no suspicion of a doublet or anything, I think then we can proceed to either archer or polar archer based on the fitness and logistics
So
permitting.
patient is hemodynamically stable, 62-year-old male, absolutely fit and fine, PS of 0, 1, and the sites are either cervical nodes or tonsil. So what would be your go-to regime here? What do you see? Do
So
you
in
do,
general
do you go for,
practice,
and do you straight away go for the therapy like RCHOP or Polar CHP and explain it to the patient that we are going to start therapy, or any diagnostic workup you want to do?
so usually one thing additionally I would like to do is assess the HPSAG and IgM anti-HPC. That is
Right.
one thing before starting any rituximab. So that is one. Otherwise, I would just proceed with RCHOP or Pola-R-CHOP.
Okay. So provided we are not discussing about any financial constraints here. So
Yes.
any one of the two, RCHOP versus Polar RCHP.
Pola-R-CHOP would be the preferable here,
Okay.
considering that the IPA score and your that it is not a double hit or something. I think in that scenario, I would prefer a DAR pop rather than a Pola-R-CHOP.
All right. Dr. Lingesh, any thoughts on that?
Yeah, sir, I would also like to proceed with Pola RCHP, but In addition, I would go think of doing a FISH testing, sir, for this patient.
Exactly.
If this patient comes to me,
Exactly.
definitely. Yeah.
So point well taken. I think it's very important to confirm it via fish testing, BCL2, CMYC, and rearrangements. Dr. Naveen, any thoughts on that?
Uh, in clinical practice, I usually when see the IHC with if CMYC is negative, I don't go for fish, even though there is a discordant rate of around 20%. That is
Yes.
CMYC being negative, fish rearrangement being positive is there. But I usually take if K67 is more than 90% with BCL6 positive and CD10 positive. In that case, I will go for CMYC for fish. Otherwise, here K67 is 80% with CMYC being negative. I usually don't go for fish in this case. And another certain workup need to be completed with this the TLS workup with serum electrolytes, calcium phosphate, and uric acid, and PET-CT and bone marrow studies has to be done with ECG and
Right.
echo for the baseline workup.
Right. So PET scan was done. PET scan was suggestive of the similar kind of picture, tonsil and the cervical node. Dr. Induja.
Yes, sir. May I know the question, sir?
So we have a case where the patient 62-year-old male has presented to you in your OPD and has undergone a tonsillar biopsy, which was suggestive of a diffuse large B-cell lymphoma,
Okay, sir.
non-germinal center type. So we are taking the case forward towards a further diagnostic workup and towards treatment as well.
So definitely a PET-CT, fish panel, high-grade lymphoma fish panel,
Right.
and basic workup, and then based on that we will carry forward.
Right. So we all agree that there is a discordance between IHC and fish for the rearrangement. So in my real world practice also, I do confirm it by fish testing and then label it as double hit, triple hit, CMYC positive, BCL2, BCL6, and then prognosticate accordingly. So again, a very relevant question. What would be your take on a patient who is not affordable for polatuzumab? Do all the clinicians have certain amount of experience about adding a third drug, or is it if the patient is not affordable, we go for R-CHOP versus not adding plus minus anything, whether it is a TKI or a bortezomib, whatever you have done in your practice, where you feel that these are the kind of patients who will require something beyond R-CHOP because they are going to fail in near future. Dr. Jarin.
Sir, in general, no, sir. If, as I was saying, only thing is the proliferated is if the K16 was quite high,
Right.
and with if the fish picked up, say, BCL2, I might err towards a DAR epoch, but
Right.
rather than that, not something else.
Right. Dr. Lingesh, any experience on adding, if it's a bulky disease and CMYC is positive, then do you go still do the same as we follow the protocol of RCHOP, or something you have maybe in your real world practice you have tried?
No, sir. Only if the patient is not affordable for POLA or CHP, as in the case in this current scenario, I would go for RCHOP rather than adding any other second line drugs because they have no proven benefits in first line settings. These
Exactly.
second or third drug in first
Right.
line setting at least.
Right. Dr. Naveen, almost the same experience?
Yes, sir. Except that if it is showing a double expressor or triple expressor in a young patient, adult patient with high K67 and everything, I slightly prefer a DA epoch plus R because there is a subgroup analysis where showed there is some minimal benefit when compared to the R-CHOP, but the
Right.
primary endpoint was met. In that case, yes, intensive regimen like DA epoch plus R in an young
Right.
fit patient.
Right. Dr.
Otherwise,
Induja?
for R-CHOP, yeah.
Same, sir. Other than R-CHOP, if it is
Same.
a very triple hit or very high-grade lymphoma or epoch, otherwise nothing else.
Right. So, any thoughts on doing? I agree to all what you said. I think I also practice the same. It is giving R job, but I have tried giving ibrutinib or lenalidomide in certain subset of patient. But to an extent, I think majority of the I don't have a head-to-head comparison, but I think you can consider there is no proven data about. I think there is a subset in young patients in one of the trials regarding adding ibrutinib, but otherwise, as of now, the standard is R-CHOP. So I agree with you all. So any thoughts on doing an NGS testing if your patient can afford anything? Would it be relevant doing here NGS testing, next generation sequencing? Dr. Jarin.
So Personally, I do not do it, sir, but I have heard my colleagues doing it recently. To be
Right.
very honest, I'm not very sure how much it will influence the making as of now with whatever
Right.
data we have
Right.
currently. I think currently the only things that might influence is a BCL2 or a MIC,
Right.
usually which is confirmed by a fish. So
Right.
that's my thought.
So, Dr. Lingesh?
Yeah, sir. Personally, I also won't prefer to do NGS in upfront setting because the studies are being evolving based on the NGS and the results based treatment. But currently, I won't prefer NGS in the upfront settings other than routine fish testing, sir.
Okay, so we all agree to that as of now we are not doing NGS, but we'll come to the data that has been presented in the recent conferences. I'll come to that. Whether do we all agree? I think all the DLBCLs are whether it is ABC or GCB type. There are different subsets who will actually behave differently, and I think time will tell us whether polatuzumab has a beneficial role in all the ABCs or whether it is only ABC and not adding to GCB. So another relevant question related to this is, do we explain it to the patient that if a patient like ABC, bulky disease, comes to you with high IPI, so do we have a word in our day-to-day counseling about that these are the kind of patients who will actually fail and who will actually end up receiving a second line therapy like a transplant or a CAR T cell therapy. So do we have this kind of discussion on day one, or is it like we explain about the current therapy? And so, Dr. Induja, maybe you can take this. It's an important point. I think majority of the patients who will have a bulky disease, as a clinician, you also have that sort of gut feeling that these are the kind of patients who will actually fail. So do we explain it that one should be inclined towards taking polatuzumab into the picture? Dr. Induja?
Sir, for high-risk patients, definitely we should give the option of polatuzumab because other than this, none has done better than R-CHOP. We should definitely give because it is
Yeah,
only 60% cure rate with even all the advances. So
absolutely. Dr.
high-risk.
Jarin, yeah. Dr. Jarin, any thoughts on second line therapies? Do we really hold up that discussion on day one?
No, sir. No. At
Okay,
least until the interim, like PET after the fourth cycle, I would not.
I will not. Dr.
Yeah.
Naveen?
No, so not on day one because it's not all 100% who are going to fail. Almost 60% they are going to benefit. So the rest 40% we will not be knowing. So just expanding on day one with the second line treatment, the patient will not come back actually.
Yeah, absolutely. I agree with you. So this was a case of DLBCL non-GCB type, and again we had a discussion about fish testing. Yes, routinely we should do it and label it as whether it is rearrangement BCL c-MYC or BCL2 BCL6 positive or not. All the investigations, as you rightly pointed out, before using rituximab and before taking the TLS picture into account. I think I agree with you. All next generation sequencing, I'll come to that because the data is important and it is coming up in a big way that I think maybe 2 years down the line we'll be discussing about which is a subset, a cluster-based DLB subset, which is going to actually have an impact of adding polatuzumab in those subset of patients. So do we consider this patient at high risk of relapse? Yes, we agree that non-GCB and high IPI would be the features where one should definitely consider that these are the patients who will actually fail in the near future. Do we explain the patients on about the second line therapies on day one? I think as a clinician, after the first PET scan is available, we usually hold up that discussion. Otherwise, I agree that 60% of the patients would achieve remission. So on day one, I might not discuss, but later on going as the treatment progresses, I think on interim scan, one should definitely discuss about the relevant second line option. So bulky disease, this was the patient demographics in the original trial, 40% around bulky disease and 40% had MYC and BCL2 expression. So ABC was there in around 35% of the patients and high IPI in 62% of the patients. So this was an important data that came up in 18, the ICML, whether the addition of polatuzumab with RCHP in DLB class defined molecular subsets makes a difference. And this was from the POLARIX trial only. So here the DLBCL subtypes were actually divided into 5 cluster groups, C1 to C5. I will not go into the detail. I will just highlight about that patients with C5 DLBCLs had a 5-year PFS higher with POLA RCHP rather than the standard R-CHOP regime, where 70% versus 42% and a hazard ratio of 0.38. Why? Because the polatuzumab domain, it is an antibody drug conjugate which actually works on the B cell receptor, and as the class defined subtypes, I think there are basically different key mutations that are different in different cluster subtypes. Like for class 5 where we are discussing right now, it is the MYD88 and CD79B. So basically you are discussing about what are the relevant mutations in each cluster type. So this was the ABC type which was being driven by MYD88 and CD79B. So that is why the heterogeneity in the DLBCL comes into picture, and the signaling of the B cell receptor becomes most important, and that is why the importance of adding polatuzumab here would be of utmost importance, because this is a anti-CD79B driven antibody drug conjugate, and that is why C5 drove the maximum amount of benefit here. And the clinical settings, one again important point I would like to highlight here is like the primary CNS lymphomas, testicular DLBCLs, extranodal DLBCLs would be one category where one should ponder upon uh, adding this kind of drug or not. So ultimately, the maximum benefit was there in C5, followed by C1, followed by C4, followed by C3, and C2 did not have any subsequent sequential benefit with the addition of polatuzumab. So if I have the option of doing a molecular cluster based classification, it would be either C5 or C1, where I would definitely consider adding polatuzumab, and I'll convince my patients upon using uh, polatuzumab. So again, this is the journey. As we have already discussed, 60% would go into remission, but 40% would require second line therapies with CAR T and autologous transplant. So choice of therapy we have already discussed. R-CHOP versus POLA R-CHP. These relevant points are the important drivers which one should take into account. IPI, cell of origin, bulk of disease, FISH and NGS testing. If available, that is optional. As of current standard, we are not doing NGS. So 2022, it was approved. Any third drug, the panelists did not agree. I have some real world evidence about adding ibrutinib and lenalidomide, but difficult for me to conclude whether the addition of third drug would make some benefit or not. We all have been discussing about using anti-CD20, addition of any targeted drug, changing the chemotherapy backbone. I agree with using a RDA epoch based approach in some of the selected patients apart from R-CHOP. So maintenance have failed. Almost 13 different trials have been done where we did not have that sort of benefit. So this is the POLARIX trial, which was a randomized, double-blind, placebo-controlled trial where patients with IPI 2 to 5 were randomized between two arms. The difference was adding polatuzumab with RCHP versus the standard, which has been there since almost 2 decades, that is R-CHOP. The primary endpoint was a progression-free survival, which, now coming on to the last part of the discussion, is the EFS benefit good enough to change our practice? So I will start with Dr. Jarin. We all have discussed many a times in our discussions and CMEs that overlapping curves in OS is what is maybe prohibiting us from using polatuzumab. But is the EFS benefit good enough to change the practice here in DLBCLs? Dr. Jarin, I'll start from you.
So I think for a well-selected patient, definitely it is worth it, worth using. So I would definitely use it.
So, Dr. Naveen, overlapping curves in OS, does that prohibit you from using polatuzumab?
No, not at all, sir. Actually, the primary endpoint was PFS and the secondary endpoint was EFS and OS. So
Right.
in all the hemato-oncology trials, you will see the primary endpoint as PFS only. So it is a clinically meaningful surrogate marker which can translate into the OS, but not nowadays because of the advent of many second-line therapies where the OS being driven by the second-line therapy. So here, the PFS 24 is actually a good surrogate marker for deciding a practice changing actually. So over the last 20 years, we did not have any therapy other than RCHOP for this. So this is the first trial to show the absolute benefit of around 5 to 6%, both in the PFS and also in the EFS. So it's
So
actually practice changing rather than OS. Because, and you can see the OS previously at 2 years, it was 0.94 hazard ratio. At 5 years, it was 0.85. So the events are happening, but it is not still mature. So you need some more years, at least 2 or 3 years to show the OS benefit. And the curve is slightly started separating now. So we cannot wait for another 3 years to make sure that the OS is also benefiting. With this PFS benefit, yes, it is good for practice changing in certain high risk or ABC subtype like double
so
expression. Yeah.
you hit the nail right on the head. I think I agree whatever you said. So, Dr. Lingesh, early versus late. So, in high risk patients, what are your thoughts on whether you see an early relapse or is it after 3 years? What and your comments on EFS 24?
The EFS 24 is almost a surrogate marker. The event-free survival at 24 months transforms into OS, sir, which is matched for the age and standard for the general population. So, the patient with high risk of DLBCL, they commonly relapses at early, sir, compared to late relapse, sir, as far as I am concerned.
Yeah, I agree with you. So we'll come to that. So this is the primary endpoint of a difference of around 6.5% at 24 months, which translated into a 27% reduction in the relative risk of disease progression, relapse, or death compared to R-CHOP. So this is the exploratory analysis, and we all have discussed many a times. It is the IPI, it is the double expressors, it is the ABC types, which in where we are inclined towards adding something beyond the R-CHOP regime. So PFS again, very similar curves. Majority of the times, 24 months is the time frame where you see majority of the relapses, and after that, 24 to 36 months, 3% disease relapse rate. So I would agree that EFS 24 is a surrogate marker, and we'll come to that in the coming slides. This is a controversial slide. OS, as Dr. Naveen pointed out, events are happening and ultimately it will translate into an overall survival. But with the advent of second line therapies, I think for DLBCLs, EFS is a relevant marker and a surrogate endpoint of overall survival, where one should not hinder in using polatuzumab apart from the patient subtype. So this is some of the analysis which I could drive whether PFS is a surrogate endpoint or EFS is a surrogate endpoint. So best established is again overall survival, but again 13 multi-center studies, more than 7,500 patient PFS, 24 ultimately correlated with overall survival, and it is a surrogate endpoint. Newly diagnosed DLBCL patients take a median of 4.5 years to complete the enrollment and 8.42 years to be published. So it takes a very long time if we take a overall survival as a
Dr.
endpoint.
Jayachandran here. Sorry to interrupt.
Yes, sir,
Sorry,
please go ahead.
Dr. Sandip. Sorry for joining late. It's a nice thing. I wanted to just bring in one point. So remember the old SWOG study, wherein you started seeing difference or deaths in patients or progression in patients late after the 8 years. Okay, that came into picture about 5 years ago when the 8 year, 10 year survival was updated. A lot of drop in survival was noted. And as you said exactly, it takes a longer time for these things to drop. And we always say that in DLBCL, the first treatment is the best treatment. And again, these all most of the data comes from West, where they have access to a lot of newer treatments and also the CAR T for all patients. But in India, we do not have any newer treatments access accessible to all the patients as of now. So EFS is a beautiful endpoint and is a very acceptable endpoint in DLBCL at any point of time.
So very nicely summarized, sir. So actually, I want to add on one point. I think we were having a international speaker program here in Chandigarh last year in our hematology update, and ultimately I forgot that gentleman's name. And he was from London, and he said that in our setup, once a patient is diagnosed as having diffuse large B cell lymphoma, we don't look at ABC or GCB types. We have a government system where government is funding the programs and the drugs. So we are, as of standard, changed our practice from R-CHOP to POLA R-CHP. And in a trial-based setting, we are also sending the next generation sequencing, and the therapies are gonna, maybe I would say, refinements in the treatment would definitely be there in the coming 2 years when the NGS would become economical and we start doing NGS in each and every patient to identify that the maximum benefit could be offered to patients who are in C5 or C1 type. Maybe that would be the way to go in the coming future.
So the next point is, see, basically when I was in UK, there was a lot of two schools of thought. One
Yes,
is looking at using R polar CHP for everyone. Other schools of various consultants were like other groups of people were looking at using judiciously the polatuzumab because it was the taxpayers' money which is being used there.
true.
So they all knew that the GCB subtype you did not need to give polatuzumab.
Yes,
R-CHOP is going to do the same as R polar CHP because see the first plot or other subgroup analysis is exactly in the point zero. That
exactly.
it so people were saying that why I'm going to bother. R polar CHP is going to do the same as R-CHOP in in GCB, whereas it's going to do better in ABC subtype. So why I should be bothered? I will give R polar CHP for everyone. Is something which can happen in a place where like a UK or Canada where it has been supported by the government. Even
Exactly.
there are people who are looking at economical perspectives and saying that why should I use an expensive drug in the which comes from the taxpayers' money where I can use only R-CHOP and reduce the taxpayers, reduce the cost to the economics to the government. So in that way, in India, we should be judiciously using
Using.
polatuzumab,
Exactly.
especially when you are going to put a lot. When R-CHOP is going to do the same effect as R-polar CHP in a GCB subtype. Only thing, as you said, is we don't have access to NGS, good NGS or standardized NGS as of now to really select out the patients. That is one thing which is something. Again, we all use the Hans algorithm to classify GCP and non-GCP.
True.
As of now, we don't have the exact way of doing the NGS or this other newer types of testing to classify into ABC exactly. We know GCB versus non-GCB. Again, we are still, again, we need to judiciously use polatuzumab, especially if a patient is really affordable, then give it for everyone. But if the patient is going to have limited resources, then we should be able to
Very cautiously
cut down the
using.
price. We should not try to push. That's what my point.
Yeah, exactly. Very nicely summarized, sir. So I think we all have discussed here, and with this, I'll come to Dr. Jaya has summarized the crux of what the discussion has been till now. So surrogate endpoints, we have seen that the overall survival is
Sandeep?
yes, sir. So give
Yeah,
me
doctor.
2 minutes. Allow me 2 minutes. I'll just complete them. Then we'll have a discussion. So in 1992, US FDA instituted the accelerated approval depending on using the surrogate markers. So last important point to highlight is even in patients, those who achieve a complete remission, there is a durability of response. There is a difference in patients who achieve a complete remission. So here you can see the curves at the end of the treatment also. Those patients who have a complete remission also, there is a difference between the durability of response. Asian and the elderly subset, again, it is towards using a POLA R CHP based approach. Asians are also deriving the similar amount of benefit as in the overall population. So this is how the journey has been in the Indian perspective. As sir rightly pointed out, we should use our resources judiciously, particularly in the ABC setting, bulky disease, high IPI scores. So these are certain subtypes where one should definitely consider something beyond the R-CHOP-based approaches and subsequent therapies. The possibility of using a CAR T or a stem cell would definitely come down to half, as you can see in the numbers, once you are using the best agent in your first line, that is polatuzumab with RCHP. So I thank you all my panelists and Dr. Jaya sir for enlightening us. And I think we can have a final comment on whatever we have discussed. Maybe Dr. Naveen, you are trying to put in something.
Yes, sir. Yeah. From the molecular classification, as they have published the POLARIX trial, the previously 2018, I think DLBCL, there were four molecular subtypes like EZ, B2, BNP or N1 and MCD. Now they have classified to 1, 2, 3, 4, 5, which where
Right.
the fifth subset is actually where the polar RCHP is working well. And the fifth
Yes.
subset is nothing but mid-88. Mid-88 is actually present in almost 19% in ABC subtype. So by the in India, actually by the Hans algorithm itself, if the patient is actually having an ABC subtype, and we are having the data that polar RCHP is working well in ABC subtype. So only 5 to 10% population will be affordable for this polatuzumab drug. So if the ABC subtype is there, yes, you can, instead of going for NGS, if the patient is not affordable for that, you can directly go for polar RCHP because mid 88 is almost 99% is present in ABC subtype only.
So I think it is about delineating the proper pathway. That is what is being highlighted in the paper that I presented. That is, polatuzumab works better where it is basically B cell BCR signaling is dominant. That is CD79B dominant. So majority of the times it is cluster 5 followed by cluster 1 followed by cluster 4. So that is why they hypothesize that C5 is the cluster which had the maximum amount of benefit. But I think a lot of information will come in the coming years and will have a clear delineation of the pathways, that where does it act and which pathway is actually CD79 driven or the linked pathways also. So that is why it is not only C5 which is being benefited, it is C1 and C4 which are not directly linked with BCR pathways, but some linked pathways are there which will actually amount in benefiting why you have added polatuzumab there. So thank you, Dr. Mean, for that. Thank you. So thank you. That's all from my side. I thank you all for giving me the opportunity. Thank you.
Thank you, sir. Thank you so much for the wonderful panel discussion. I thank the moderator and the panelists for this. And without the further ado, I would like to move on to our next session. We'll move on to the expert talk on role of polemizumab in aggressive B-cell lymphoma. It's an honor to invite our program director, Dr. P.K. Jayachandran, sir, who is a consultant medical oncologist in Hemato Oncology from Apollo Cancer Center. Sir, over to you, please.
Thank you. Can you put on the slides because I was just running around? Can you just
Yes.
post the slides for me?
Yes, sir. Just a minute, please.
Let me download otherwise. Okay, fine. Sure.
Hope it's on the full screen, sir.
Yeah, it's on the full screen. So can I have the next slide, please? Yeah. So we all know that DLBCL is I think we had a lot of discussion on the most common lymphoma which we treat come across as DLBCL in most of the times. Next slide, please. And cure, as I said, I was telling in the panel discussion that the first line treatment is the best treatment to achieve the maximum amount of cure. And again, drugs, the intensity, density is very important in DLBCL to achieve the cure. And even though these are toxic, we need to maintain the intensity to good extent to achieve the maximum cure. Next slide, please. So next slide, please. This I think it's been shown. So again, as we all know, that's been more than 2 decades since we started using the tuximab outside the India, but in India it's been since 2006, 4, 5, 6, somewhere around that time, as the tuximab came into India, and then it's been under the same treatment. It's been going on till almost till 2022, 23. We have been using RCHOP as a standard of care in between. A lot of next slide, please. This is the Indian data set, which is shown that we have a 2-year PFS of about 69% and 2-year OS of 79%, and it is clearly lesser than that of the Western data. Next slide, please. And also again, RCHOP, are we okay, happy with RCHOP in all population? Again, in patients with high PI, dual expressor, then double hit lymphomas, patients with a non-GCB subtype, and atypical lymphomas having burst lymphomas, testicular lymphomas. I think RCHOP may not be really enough. Next slide, please. So again, I think this slide was shown by Dr. Sandeep, and there was a lot of gimmicks happening. They tried to escalate the chemotherapy. They tried to increase the intensity by increasing the dose of doses like mega chops, CHOEP. All these things were tried. Then tried to change the partner to Gazyva. They also tried to change the partner to ofatumumab. This didn't work. They also had tried to add another chemotherapy like gemcitabine. It did not work. Recently, venetoclax also did not work. And if you look at the addition of novel agents like rituximab, lenalidomide, bortezomib, ibrutinib, bevacizumab, nothing really did make a difference in the survival of R-CHOP. Even maintenance chemotherapy like the tuximab maintenance, anastrozole maintenance, everolimus maintenance, all these things really did not make any difference in the survival except for R-CHOP. It held its fort for almost 20 years. Next slide. So we need to, as you said, next slide, please. So again, our polar chip is something which we have in our armamentarium now. Next slide, please. Next slide, please. So again, we all know this is a anti-CD79B ADC, which has vedotin, that is a monomethyl auristatin E as a link with a linker. It's a microtubule inhibitor like vincristine or taxanes. And once it gets into the cell, the ribosomes cleaves and digests the antibody protein. The toxin is released, which is a toxic microtubule inhibitor, so that the cell is pushed into the death. Next slide, please. So next slide, please. We all know the POLARIX trial. Again, this is a randomized controlled trial between R-Polar, CHP, and R-CHOP. Next slide, please. And this is a trial designed about 18 to 80 years. IPI 2 to 5, previously untreated, newly diagnosed DLBCL randomized to 1:1 R-Polar CHP versus R-CHOP, followed for 6 cycles, followed by 2 cycles of maintenance, 2 cycles of the single agent rituximab of 7th and 8th cycle in both the arms. Next, the primary endpoint was PFS. Again, people were all discussing about the PFS. So see, I feel this PFS is not a very great endpoint, but EFS is something which is a great endpoint. So what is the event? So PFS may miss some events, basically. If you look at PFS, failure to achieve CR is an event. Failure to achieve CR at the end of 6 cycles or 4 cycles of R-CHOP is not good, but the PFS does not fix this as an event. So that's something which we need to keep in mind. So I always feel that failure, FFTF, that is free from failure, first line failure. Basically, you need to keep EFS and keep event as one of the events as failure to achieve CR. That would be a good endpoint. Even though patients who achieve partial response will relapse within a few months, still that too few months may make big difference in survival endpoints. Next slide, please. And PFS at 2 years showed about 7% incremental benefit with the use of R-Polar CHP. And at 5 years, also the same maintained around 6% incremental absolute benefit was seen. And next slide, please. And you could see the number of subsequent therapies was higher with the use of R-CHOP as the CAR T, stem cell transplantation, use of bispecifics, use of a platinum chemotherapy, whatever be the therapy, it was almost half of the need for subsequent therapies. Next slide, please. And as we were all discussing, OS is still not achieved. I think over time, when we cross 8 to 10 years, we may see some OS benefit. But as of now, we are not seeing any OS benefit. But are we happy? Again, we had a long discussion about this in the panel discussion. Next slide, please. Again, fast plot, we all been discussing this. Are we really pushing GCB more for our polar CHP? Yes, our polar CHP and ours almost going to do the same in a GCB subtype DLBCL. So if the patient is really not affordable, then I would go for our CHOP. Whereas when the patient is affordable, then even for GCB subtype, I am very much comfortable with our polar CHP. Next slide, please. Next slide, please. Then we had a lot of discussion about these subsets using this nanostring analysis. Basically, see cluster 1 and cluster 5. The cluster 5 is something which is going to be very extremely sensitive to the polatuzumab. Cluster 1 again, which are the malignancies, the LBCLs, which have been transformed from occult marginal zone lymphomas. And next is going to be cluster 4. Next slide, please. Again, AB, this is what we were discussing, whether GCP is going to really do any difference. Again, this is based on the sequencing, not based on the Hans algorithm. That is why when you're going to go with Hans algorithm, if the patient is very affordable, do not take a chance, go for R polar CHP. And in ABC, there's no question, R-CHOP is inferior, R polar CHP is clearly superior. And you can see the amount of benefit and the amount of separation of curves you can see after 6 months of treatment. And again, next slide, please. And ABC versus GCB, which we are discussing. Next slide, please. This is based on the various subtypes, clusters, which we are discussing. As I said, the patients with ABC, that is especially MCD subtype, had very enormous benefit. And EZB subtype, again, had a good benefit. And EZB is being classified into GCB subset. And it's a very small subset of patients in GCB who are going to benefit with the use of polatuzumab. So again, this is a reason why we are going to recommend polatuzumab even in a GCP subtype when the finances are not a constraint. Next slide, please. And as we are discussing over the clusters, the most benefit is derived from the C5 cluster. The next is going to be the C1 cluster. Next slide, please. And again, signatures, again, DZ signature is something which is a predictive of our polar CHP. Again, DZ signature positive patients again going to be having a better benefit with the use of R-Polar CHP than R-CHOP. Next slide, please. An external population, R-Polar CHP is going to be beneficial, better than use of R-CHOP. Next slide, please. Elderly subgroup, I think we had the same discussion in the panel discussion. Elderly subgroup, as we are going to vincristine is one of the notorious drug, very tough, and it's not very good tolerated well in elderly subgroup, a subset of patients, whereas polatuzumab is very well tolerated. So basically, when you cross that point of 7-8 cycles with vedotin, then only neuropathy sets in. Whereas when Christian even have as very bad neuropathy even after 1 or 2 cycles. So this is a wonderful drug because we're not going to cross 6 cycles of polatuzumab. It would be better to use this drug. Next slide, please. Again, the adverse event profile was comparable. Can clearly see that there was a very slight higher, not significant, not very much significant difference between the side effect profile. Next slide, please. Peripheral neuropathy, almost same because we are going to use vincristine there and here. Polatuzumab, almost similar. Again, neutropenia, almost similar. Infections, almost similar. Anemia, similar. Thrombocytopenia was similar. Cardiac arrhythmias was lesser, even almost similar. So if you look at the toxicity profiles, there's no much of difference between two arms. Next slide, please. In peripheral neuropathy, I think you can clearly see the incidence of peripheral neuropathy is going up. But compared to the polar say R-CHOP, polar RCHP had lesser incidence of peripheral neuropathy, and ear neuropathy also over time came down, and persistent peripheral neuropathy was similar in both the arms. Next slide, please. And this is a new guidelines which has been released. If you have more than 2 IPI and even less than 80 years, polar CHP is the standard treatment for patients, all patients, and R-CHOP is an alternative. Next slide, please. And DLBCL and NCCN also recommends as a category 1 recommendation as polar CHP. Next slide, please. So again, impact of POLARIX, it's the first trial after loads and loads of clinical trials done in DLBCL to improve the survival. This is the first trial which could show some modest improvement, maybe around 6%. You know, R-CHOP versus CHOP, the amount of benefit is not great. It's not, rituximab had not, like, it's not a wonder drug. R-CHOP versus CHOP, the main trial showed about 11% benefit. Now, if you look at our polar CHP's R-CHOP, it's about 6% to 7% benefit. So it's something which is very great to achieve something better than R-CHOP after a struggle of almost 20 years. Again, long-term follow-up also shows that the PFS is continuing to be beneficial. And there was some trend towards OS, and we need to wait till 8 to 10 years of time to look at this. And it's a category 1 recommendation by NCCN and various other guidelines. Next slide, please. I'll stop with this. Thank you very much. And thank you everyone for coming up with the panel discussion. I am extremely sorry for joining late because of my previous meeting. I had to, which was got delayed. I had to join late and do this presentation later than that of the panel discussion. And it was a wonderful panel. I could join on the later point of the time. It was a wonderful panel discussion which we had during the discussions. I hope there was a very good discussion before my joining. Thank you very much for joining.
Thank you, sir. Thank you so much for the discussion. And I thank all our panelists and moderator of the day for the wonderful discussion and the sessions. With this, I conclude the session. Thank you all. Good night.
Thank you very much. Good night. Bye-bye.
Thank you, sir. Good night.